to speak to us about vaccines. Dr. Kluthe entered medical school when her kids were in grammar school. She's a member of Alpha Omega Alpha Medical Honor Society and a fellow of the American Board of Pediatrics, board-certified lactation consultant. She learned Spanish during residency and focused her career on health care for the high-risk and disadvantaged children and working with breastfeeding mothers. And one of her areas of interest is with vaccines and dispelling anti-vaccine propaganda. And this is one of the topics that she's going to discuss today. So let's welcome Dr. Kluthe.
Thank you very much. Now, just let me, the first half of my talk is on neonatal vaccine strain varicella, 22 days following maternal postpartum vaccination. I was joined in this research by three varicella researchers at the CDC, 2 Utah doctors, and myself. And I thank my husband for his unending patience and my mother for her unending edits of the paper. Whoops, the slides are a little elongated. Can you fix that? Well, our case began one February morning when this infant, 26 days old, presented to a clinic with varicella. She had a macular-papular rash which began on the forehead and progressed to her torso and extremities and had become vesicular by the time we saw her. This photo was taken on day 4 of her illness. Dr. Blanca saw her and diagnosed her with varicella clinically and sent a swab for PCR testing. She consulted with a pediatric infectious disease specialist at Primary Children's Hospital. Now, newborns and infants can get varicella only if their mother never had chickenpox. Varicella is spread through inhalation of aerosolized fluid from skin vesicles and skin lesions and possibly respiratory secretions. It is extremely serious in the first 16 days of life. Older neonates, like our patient, and infants can be sick and may need hospitalization, so this was a very alarming case for us. Now, when pediatricians think of varicella, they think of this. This is a neonate with wild-type varicella. Here's another infant. Oh, this is a boy with varicella and an infant with secondary staph infection of her wild-type varicella. And you saw our neonate, our baby, very different. Whoops. I saw our infant on follow-up the very next day, and I was surprised at how mild her vaccine rash was. Then I asked the mother if she was given varicella vaccine during her hospital stay, and yes, she was given the varicella vaccine before leaving the hospital. At that point, I was convinced that this was actually vaccine strain varicella. Nonetheless, the mother said she had no rash or no skin lesions anywhere on her body at the vaccine site or elsewhere after receiving the vaccine. But I went ahead and had the swab sent to the CDC for PCR testing to look for the vaccine strain genotype. Meantime, our patient was improving. She was fussy when I saw her, and I started oral acyclovir. She developed no new lesions. She had a total of 50 to 60 lesions, remained afebrile, and fed well. She did not need hospitalization, and she recovered completely over the next week. The CDC reported that the swab was positive for OCA vaccine strain of varicella zoster virus. Genotype analysis confirmed that it was a clade 2 virus, the genotype of the vaccine, and carried the 4 specific polymorphisms of vaccine strain profile, the same as the mother was given. Now, and here she is again. You can see on this slide the very clear vesicle at the, or a blister at the top of her forehead, which is now crusting over. The Oka vaccine strain of Varicella zoster virus was licensed in 1995 and has led to a significant decrease in varicella cases, hospitalizations, and deaths. The Oka vaccine is a live attenuated virus, and it will cause skin reactions, either a local reaction or a generalized rash in 6 to 10% of adult recipients. When the rash is present, it occurs a median of 21 days after vaccination. Over 100 million doses of varicella vaccine have been distributed in the United States, and safety profile is reassuring. Before the vaccine, 50 to 70 children died of varicella each year, and most of them had been previously healthy. This graph shows the decrease in chickenpox after the vaccine. On rare occasions, a vaccinated person with a post-vaccine rash has transmitted vaccine strain varicella to another person. Only 10 cases of secondary Oka vaccine varicella have been reported in the literature among healthy recipients, and most cases were mild. All cases involved close contact with a vaccinated person who had a rash. Our patient had no rash contact. The mother denied any itching, redness, rash, or vesicles at the vaccine site or elsewhere. No other contact had recent vaccination. No previously vaccinated contact had a rash of any kind, so this excluded vaccine strain shingles as a possible source. We began exploring possible means of transmission. We considered direct inoculation of vaccine fluid from the mother's arm immediately after vaccination to the newborn's mucous membranes. We felt that this was possible but unlikely, as varicella does not survive very long in the acid mantle of the skin. We considered secondary spread through the mother's respiratory secretions. For instance, after Zostavax vaccine for shingles, Oka vaccine DNA can be found in the saliva of many recipients within a week. But Zostavax is 13 times stronger than the varicella vaccine, and viability was not addressed. And there's been no documentation of transmission by respiratory secretions. We considered breast milk, but felt that this was not likely to be the source. Oka vaccine was not found in a study of 217 breast milk samples after vaccination, and our patient only received breast milk 4 times a day. Then a query led us to discover a new possibility. Was the vaccine prepared in the mother's room? Yes, the mother remembered seeing them prepare the vaccine, and the nurses confirmed that this is protocol to prepare the vaccine in the room. The medical records confirmed that the infant was present when the vaccine was given. Now, varicella vaccine is frozen and must be reconstituted with sterile water. Then it's drawn into the syringe. And if you try to get every drop, and we all do, you get air bubbles in the syringe, which must be cleared. Of course, a small amount of vaccine will be aerosolized when the bubbles are purged from the syringe. We believe that inhalation of aerosolized vaccine was the most likely source of this infant's infection. And interestingly, her vaccine emerged on day 22 after vaccination of the mother, very close to the median time for a vaccine-associated rash to appear. So, in summary, there has been over 100 million doses of varicella vaccine distributed in the United States. To our knowledge, this is the first confirmed case of Oka vaccine strain varicella in a neonate, and the first case in a person with no exposure to a post-vaccination rash or zoster. The infant's infection was mild, in contrast to wild-type varicella, which is often severe in infants. Conclusions: inhalation of aerosolized vaccine was the most likely source. especially as the vaccine was prepared in the room with the infant. Direct transfer of the vaccine from injection site to the infant is remotely possible. Respiratory spread from the mother 5 to 10 days after vaccination cannot be excluded. And most important, vaccination of susceptible mothers in other contexts should continue, as this decreases the risk of severe disease from wild-type varicella in susceptible mothers and infants. Infants and susceptible persons should not be present when the varicella vaccine is drawn into the syringe, and vaccine aerosolization should be avoided. And that is the end of my first presentation. And thank you to our sponsors for their support. Do you want to go ahead and load the second one? My second presentation is on addressing anti-vaccine propaganda, a very different topic from our first. But the first half of my talk was on a vaccine side effect, which was mild, like most vaccine side effects are. And this half we will talk about this increasing problem of anti-vaccine propaganda. This month marks the 10th anniversary of when I first did this talk on addressing anti-vaccine propaganda. Since then, many books from physicians have come out to help in this, address this with parents, and my sincere thanks to Dr. Paul Offit for his recent books on the topic, and I recommend him to those who want to know more. I have no conflicts of interest or financial disclosures. I have written a 23-page pamphlet on vaccines, but I've never published it, and it would need revision. Now, I don't think any of us here would dispute that vaccines have saved more lives than any other medical advancement in history. Now, there is a propaganda war being waged against them, a war of distorted data, outright lies, and unusually mild disease descriptions. We must all work together against anti-vaccine lies and answer parents' questions both in the office and in our neighborhoods. In this talk, I will focus on 3 types of people opposing or questioning vaccination. We will discuss 2 anti-vaccine leaders, how to counter their lies, and finish with ideas on answering parents' concerns. This slide shows 3 anti-vaccine groups. The center represents the leaders and celebrities who write books and are on TV. The next ring, the middle ring, indicates their avid followers, the activists who are vocal in their neighborhoods, spreading anti-vaccine lies and propaganda. These people are locked into their beliefs, and most are probably unreachable. How fanatic is this group? Some members will reject the well-tested varicella vaccine, but have purchased chickenpox contaminated lollipops over the internet. Now, I don't know if these lollipops were contaminated with the saliva of children with chickenpox or rubbed on their blisters, but I doubt that varicella virus would survive shipping. I doubt that this is the best way to get immunity to varicella also. However, tuberculosis, hepatitis B, and strep can survive longer and might be transmittable by lollipop. Fortunately, laws against sending biologic agents through the mail without a license shut these websites down. So, the outer ring represents people who hear anti-vaccine information and become anxious or alarmed. They want to do what's best for their children, but after hearing this propaganda, they are unsure of what that is. When we listen to these parents and share accurate information, many will choose to vaccinate. This is the group that we want to reach. But before reaching out to parents, we must know what they're hearing. Several anti-vaccine physicians have had powerful negative effects on public confidence and vaccine acceptance. We will discuss 2 of them. First, an English physician Andrew Wakefield, alleged a link between the MMR vaccine and autism through research that we now know was fraudulent. Wakefield performed extensive tests, including intestinal biopsies, on 12 children and claimed to have identified a new syndrome, intestinal autism. In 8 children, he said that the MMR vaccine contributed to lymphoid hyperplasia and that MMR RNA was found in the inflamed intestines and that this predated autistic regression. Prior to publication in The Lancet, Wakefield held a press conference claiming that he could not support the 3-virus MMR vaccine. He claimed that a vaccine with 3 viruses increased risks of reactions, including autism. Wakefield did not reveal that his research contained many conflicts of interests. He advocated for giving a measles-only vaccine, but hid the fact that he had already applied for a patent for this type of vaccine. He did not disclose that lawyers suing the MMR manufacturer had paid him £400,000, which at that time was about $800,000, to do the research, and that these lawyers had recruited 5 of the 8 children with autism for his study. Wakefield also did not say that his research contained falsified data. Contrary to his claim, measles MMR was not found in tissue samples. His research assistant, Nicholas Chadwick, who took the biopsies from the operating room to the lab and did the PCR tests, testified in court that the samples were negative for measles RNA. When the study claimed otherwise, he removed his name from it. Wakefield also didn't mention that some of the children had language delays and autism symptoms documented in the chart prior to receiving the MMR vaccine. Brian Deere, an investigative reporter, brought these allegations to light, and they have been confirmed in the courts. Since then, 10 of his co-authors withdrew their names from the study. Wakefield's medical license was revoked for fraudulent research and callous disregard for children's safety. And in 2010, The Lancet retracted the article. However, profound damage had already been done. Many parents across Europe and the US started refusing the vaccine. Measles is no longer a disease of developing countries, and some of us may see a case of measles in our careers. Here are a few outbreaks, and as you can see, the number in the thousands, up to 14,000 in France last year, 222 cases in the US, about 16 of those in Utah. Measles is highly contagious. It can be passed through the air in the emergency room, waiting room, or in your office. Encephalitis, even in modern countries, occurs in about 700 cases, and mortality is 1 in 1,000. The MMR side effects vaccines are nothing like this. There is less than a 1 in 5,000 risk of a febrile seizure, which is followed by complete recovery after the vaccine. There's no increased risk of encephalitis, and the risk of a serious sequelae has never been shown. Serious illnesses are less than 1 in a million, which is, serious illnesses are 1 in a million if you don't get the vaccine as well, and you don't get measles. In response to Wakefield's allegations, multiple studies looking for an increased risk of autism after the MMR have been done. The challenge is that autism symptoms are subtle in the first year, but become increasingly evident in the second year. The MMR vaccine is scheduled to be given early in the second year, just before we would expect to begin seeing concerns for autism arise, whether the child was vaccinated or not. Thus, large studies are needed, and many of these have been done. Paul Offit, infectious disease specialist, writes, 12 separate studies in several countries compared children who had or hadn't received the MMR. The risk of autism was the same in both groups. This Denmark study is an excellent example. It was actually done in 2002. Denmark's disease registry allows them to access data on diagnoses and vaccinations. They found that autism and autism spectrum diagnoses occurred at the same rate in MMR vaccinated and unvaccinated children. No study has found any link between autism and vaccines. But to this day, parents anti-vaccine advocates and some parents continue to support Dr. Wakefield. This vaccine shows a child with measles. After 3 days of high fevers, cough, and conjunctivitis, the rash emerges. My earliest childhood memory was when my older sister had measles. She had fever of 107, a febrile seizure, and was sick for 2 weeks. I remember the fear in the house, the dim lights, the hushed voices. Our doctor was amazed that my sister survived without brain damage. I was given gamma globulin because there was no vaccine. When talking to parents, I want them to be able to picture the disease, so I share this story with them. Another anti-vaccine activist is Dr. Robert Sears, or Dr. Bob, a pediatrician and self-styled vaccine expert who undermines vaccines and parents' trust in their doctors. Dr. Bob has never done any research on vaccines, but he has written a book. And some parents see him as an expert and carry his book into my office, and this book contains numerous errors. Here is Dr. Bob on measles. Measles is now extremely rare, and in most cases harmless. The possible complications of measles, mumps, and rubella are very similar to the side effect of the vaccines. What world does he live in? He questions tetanus, if some vaccines are even necessary. He states that tetanus is not an infant disease, and a child could get the tetanus series as a teenager. How many of you have had a child who stepped on a rusty nail? Probably quite a few. And this, I suppose, is a very small adolescent. Worst of all, he proposes his own vaccine schedule with 1 or 2 vaccines every month. He also suggests skipping some entirely. With his schedule, some vaccines are given a month late. In reality, most families do not return monthly, and vaccines end up 3 to 12 months late. To counter Dr. Bob, Wakefield, and others, meet with parents when you're not scheduled to see patients. Be ready to discuss the infant's immune system, as some parents don't want to vaccinate such a small baby. Explain that decreasing maternal antibody makes the infant vulnerable to invasive infection. And as you can see, maternal antibody falls, has a nadir of it at about 6 months, and then the infant's own antibody begins increasing. Draw a picture or show parents a graph similar to this and a graph showing meningitis levels increasing over the first year, and tell them that because of low antibody levels, infants are more susceptible to meningitis and bacteria in the blood, especially in the first 4 to 12 months. Here is a little girl with Hib meningitis. Dr. Bob writes, Hib is a bad bug. Fortunately, it's rare. Before the vaccine, there were over 10,000 cases of Hib meningitis a year. Now, much fewer than 100. But during the vaccine shortage of 2008, 4 unvaccinated infants in Minnesota and Pennsylvania died of Hib meningitis. When talking with parents, tell them that today's vaccines are mild and safe, and most children have few reactions. And when we talk about individual vaccines, I do go over rare vaccine side effects, but they are rare and self-limited. Infant vaccines contain only a few different types of particles which stimulate the infant's immune system to make protective antibody. This is important because many parents are afraid to overwhelm the infant's immune system with vaccines. Tell them that vaccines give the immune system a practice drill, just as our Army has drills so that they are ready for the real fight. We also need to talk about coincidences. There are some very sad stories about children who were vaccinated and then had life-threatening illnesses. Explain that sometimes an infant or child coming down with a serious illness looks well and could be vaccinated. The illness will follow the vaccine but not be caused by it. Very large studies are done to differentiate between coincidental effects and actual vaccine side effects. And I find that parents can understand this concept, especially if they are given examples. For instance, a completely unvaccinated toddler was in my office. I was seeing the sibling. But I suggested vaccinating him even though he didn't have his appointment that day. His mother decided to wait until Monday when he had an appointment. 30 hours after I did not vaccinate him, he developed a fever of 104 and had a febrile seizure. Had I given the vaccines, his mother would have blamed the shots and had a story for the internet. And there are other stories. One person stood in line to get vaccines for his 2-month child, but the line was so long in England that he went home. That night, he put his child to bed, and during the night, the child died of SIDS. Had the child been vaccinated, it would have appeared that it was related to the vaccine. Lastly, I talk about natural. When parents think of natural, they think of naturally good, but nature is not always kind. Infant deaths are natural, but it's not the kind of natural that we want. The truth is that infant deaths and sudden infant death syndrome have fallen as more vaccines have been given. So in summary, when talking to parents, compliment them for caring so deeply about their children. Invite them to come in when you're not scheduled for patients. Listen to their concerns. Remember that they are sensitive to feeling talked down to or scolded. And share disease photos, disease stories, research, and give them literature. Here are my grandchildren. They were born naturally, exclusively breastfed for 6 months, and then started on homemade baby foods. And they are fully vaccinated. Embrace what is natural and good, not the diseases. Thank you very much. It's been an honor to be here. Thank you. Any questions? Okay, thank you very much. It's been an honor to be here.